هي لسه مش صايرة إلا ربع، بس I think ممكن نبلش. شو رأيكم؟ خلص بكير. Yeah, just 2 minutes. أي حدا متأخر بعد 2 minutes, that's fine. Okay. So my name is Dr. Asil Zghayr. I'm a general nephrologist along with transplant. So I'm a general and transplant nephrologist. I joined recently to Yarmouk University. So I already know that this is your third week and you took only the cardiovascular system, right? Okay. So I hope that you already know how to take a history. So always remember, whenever you take history, you should go through the same steps every time. You always should start with the chief complaint, and once you know the chief complaint, then you have to analyze the chief complaint and look if there is any other associated symptoms in the form of a history of presenting illness. Once you're done with that, you can do review of systems, or you can do post-medical and post-surgical. You should also do medication history or history of allergy, family and social history. You can do the review of system or systemic review at the end of your history. I usually prefer to do that after the history of presenting illness. But again, you can pick whatever you prefer, and in both ways, they are correct. So yesterday, I believe that Dr. Akur already spoke about the most common presentation or manifestation or symptoms that usually patients with respiratory disease present with. So he already, I believe he already discussed with you guys the shortness of breath, cough, hemoptysis, and wheezes. Usually they are the most common symptoms, but we also gonna talk about another important symptoms that you should know, and you should always ask whenever a patient or whenever you suspect a patient has a respiratory disorder or respiratory disease. We will start with the stridor. So as a definition of stridor, it's known as a harsh, grating respiratory sound. And that usually happens due to the vibration of the narrowed major bronchi or the narrowed trachea. So whenever there's an air whenever there's air enter a narrowed tube, then there will be turbulence of the flow. And that would cause a sound, and that sound, we describe it as stridor. Stridor could be inspiratory or expiratory, depending on where the obstruction is. Usually, if the narrowing is in the extrathoracic space, in another word, if the trachea is the one that's involved, or if there's the narrowing is in the trachea. So during inspiration, we know that the pressure inside the trachea will be lower, so that will cause narrowing. If already the trachea has pre-existing narrowing, then when you have inspiration, the narrowing will increase, and that will cause inspiratory stridor. The opposite happen if the obstruction more intrathoracic. Means like if you have the obstruction in the bronchi that's intrathoracic, then during expiration, the parenchyma will compress the major bronchi or the bronchis, and that will cause narrowing. And if you already have pre-existing narrowing, then that will cause expiratory stridors. We have some cases that you will have a biphasic. In another word, you will have inspiratory and expiratory stridors. And a common example for that is the patient with goiter. So goiter, we know that you have a fixed obstruction to the trachea. So you will have a turbulence of the flow, and then you will have fixed narrowing. that will cause inspiratory and expiratory stridors. So stridor usually it's hard to miss. You can pick that the patient has stridor very easily. Even the patient will tell you, like, I'm having this harsh, annoying, embarrassing sounds. Another common symptom is the chest pain. And again, chest pain is an red flag symptom, is an alarming symptom. Because the chest pain, or the differential of chest pain, can be very serious, can be life-threatening if the patient has an MI, or it could be just a simple self-limiting cause of the chest pain, like a musculoskeletal or rib fracture, or just musculoskeletal chest pain. So it's very important to know how to analyze the chest pain, because you could admit the patient to the ICU, or you could just send the patient home and say, just take some analgesia. When you think about the chest pain, then you should put around 4 to 5 systems to review to know what's causing the chest pain. Again, the most serious and usually the first system you should start with is to whether or not this chest pain is caused by the cardiovascular system. And usually if the pain arises from the cardiovascular system, usually the myocardium or the pericardium is usually involved to cause the chest pain. If it's not the cardiovascular system, then you could think, oh, maybe it's the lung that's causing the pain. And usually it's not the parenchyma of the lung, and it's not the visceral pleura that cause the pain. It's the parietal pleura, because we only have somatic innervation to the parietal pleura, but we don't have any somatic innervation for the parenchyma or for the visceral pleura. So only if the parietal pleura is involved in the underlying illness or the underlying disease, you will have the chest pain, or you have what we're gonna describe in a minute, the pleuritic chest pain. Chest pain can also result from gastroesophageal system. Usually if a patient has a reflux or has a heartburn, then you would know that the patient has a GERD. Then GERD can cause, dry cough can cause also retrosternal and central chest pain. Like a simple cause or a benign cause of chest pain could be, again, from the musculoskeletal, or could be radiated pain from subdiaphragmatic organs, mainly the gallbladder. If you have cholecystitis, some patients would have a referred chest pain. So that's why it's very important whenever a patient tells you that I have a chest pain, you have to take that very serious, and you have to analyze that thoroughly. Again, chest pain is just like any other pain. You have to go through the Socrates. Socrates is very important. It makes you think in a systemic way, and you won't miss any red flag or any alarming symptom or alarming description of the chest pain. So when a patient says that I have a chest pain, so the first thing you should ask, could you describe exactly where your chest pain is? So if a patient say I have retrosternal chest pain, you should take it more seriously than a patient who would say, oh, I have a lateral chest pain. A lateral chest pain could be a pleuritic chest pain, could be kidney, okay, it's more flank if it's a kidney. It could be musculoskeletal chest pain, but less likely to be from the heart, or could be from the MI. Usually patients with MI, they would say most of the time they would have a central retrosternal chest pain. The onset of the pain is also important. Some patient would say, I was sitting, doing fine, I didn't have any symptoms, I was just watching the TV, and then all of a sudden I have this chest pain the severe chest pain with a severe shortness of breath. So you would think that the differential diagnosis of that is different than a patient who says, I have chest pain in the last few hours, that the chest pain starts like when I was walking and then start to get more severe with time. So the sudden onset chest pain, what it could be? MI is less likely to be sudden or like within a second. It's more like gradual exertional chest pain. PE can present with a sudden shortness of breath or a sudden chest pain, where the MI or pneumonia or thoracic chest pain, they happen more gradual. But again, when we say gradual, it doesn't mean like over days. We are talking about hours or sometimes like more minutes. The characteristic of the pain, so it could be a stabbing chest pain. Some patient would say like it's a heaviness. They feel like like an elephant is sitting on their chest. Or patient would say like, I feel like there's a block on my chest. So that's an alarming. That could be an MI or could be an angina. Where a patient will say like, or when you ask a patient, could you describe your pain? And then they will say, it's hard for me to describe that pain. It's just like I feel there's some annoying pain, but like I don't know how to describe it. Usually we say this is a dull pain. Dull pain is like less likely to be an MI, but again, we don't have anything in medicine that's never or always. So we always live in the gray area. So adult pain is less likely to happen with MI, but doesn't mean that adult pain is not an MI. Usually patients with malignancy, they can present with dull pain, but it's not 100%. The radiation of the chest pain is also important because where do we usually have a radiation if a patient has an MI? So somebody say left shoulder, jaw, and neck. So they are the most common radiation for cardiovascular chest pain. The patient will say, I have a central chest pain. The pain goes to my left side, or some patient will say, like even I have a jaw pain. They can just present to the ED saying they have a jaw pain. But when you dig deep, you will realize that it's actually a chest pain that radiates to the jaw. Some of the patients will have bilateral radiation to the both shoulders. It's less likely if the radiation to the right side, because usually it radiates to the left side. Some patients would say I have chest pain that radiates to the back, and that also can be from an MI, usually posterior MI can have a radiation. What's that? Aortic dissection also can present with radiation to the back. So both posterior MI and aortic dissection are common disorders that could present with a central chest pain with a radiation to the back. But they're not the only disorders. They are the most alarming or the most serious disorders that you should think about if the patient describes such pain. The associated symptoms also help you in differential, like a patient with a chest pain, with a fever and cough, you would think in a different way than a patient with a chest pain, PNDs, and shortness of breath. Shortness of breath with PNDs, then you would, or plus minus orthopnea, then you would think, oh, could be a cardiovascular cause. Or a chest pain with fever and cough, along with sputum, then you would think this is mainly the lungs that causing the chest pain. So associated symptoms usually help you in your differential diagnosis. The timing of the pain is usually this pain is a constant chest pain. Is it an intermittent chest pain? Is the chest pain present all day, all night, or just during the day and get better with, or at night? Or the exacerbation or the relieving factors for the pain. Does this pain get worse on exertion and improve with rest? So that would be an alarming that this could be an exertional chest pain. Another word could be angina or could be an MI. or this chest pain get worse when with movement, or get worse with cough, or when the patient talks, then that means it could be a pleuritic chest pain. Pleuritic chest pain, you should know how they usually present. Usually patient would say, I have more, could be localized chest pain, could be lateral, could be central chest pain. But what's specific for the pleuritic chest pain, that patient would say, when I talk, or when I breathe, or when I cough, the pain is getting worse. So I'm trying to suppress my cough just because of the pain. Then this is more likely to be a pleuritic chest pain. And the reason behind the pleuritic chest pain is because you have inflammation in the parietal pleura, whether that inflammation from infection, whether that the inflammation from malignancy, or any other cause of inflammation. And whenever you breathe, then you will have the movement between the chest wall and between the parietal pleura, and that would stimulate the chest pain. Usually patients say, I have a sharp stabbing chest pain. That also could be pleuritic chest pain, but again, it's not a must. The relieving factor, like some patients would say, I took a sublingual pill I have in my pocket, and that improved my pain. So again, this could be an MI. Or a patient say, it gets worse when I'm lying flat and improve by sitting. So that could be, what's that? Pulmonary what? Pulmonary edema can present with that, because usually when it's more of shortness of breath that gets worse when they're lying flat. Heart failure is the same as pulmonary edema. Pericarditis. So pericarditis can present the opposite, like when they're sitting, the pain is better than when they're lying. The severity of the chest pain is subjective. Like some patients would describe the same pain to be 4 out of 10, but other would say 9 or 10 out of 10. So it's very subjective. Usually diabetic patients, they're less likely to present with chest pain. So they could have an MI and they only have a shortness of breath. And when you ask them, do you have chest pain? They would say, no, I don't have chest pain, even if they have acute MI. So again, the severity is very subjective. Like 10 out of 10 pain is usually similar to the labor pain or to the renal colic. Like you could ask if a patient ever had a renal stone, and then you say, is this pain is similar? You have a question? Okay. So again, always remember to ask about Socrates whenever you have pain, whether is it abdominal pain, chest pain, leg pain, any kind of pain. You should start by analyzing that pain by going through the Socrates. If the pain is musculoskeletal pain, then usually the patient will describe that pain to be more like a lateral localized chest pain. Even if they present with a central chest pain. For example, a young patient or a middle-aged patient with no past medical history, the patient comes to the ED, say, I have this pain, it's more central pain, it has been ongoing for the last few days, there's nothing that exacerbate or relieve the pain. I didn't try any medication to get the pain better. And when you examine the patient, then you will realize that this pain is very localized. Even if they say it's central, but it's just localized to the sternum or they're localized to the ribs. So that could be from an inflammation in the cartilage between the ribs and the sternum, and we call that the TZZ syndrome or the costochondritis syndrome. Or if the patient has an inflammation in the intercostal muscles, usually caused by the Coxsackie virus, then they will have something we call Bornholm disease. They're uncommon, they're a very rare disease, but it's important to think about them because they are just self-limiting disease. You can just give them some analgesia, give them some NSAIDs, and send them home and tell them that the pain would get better in just a few days. A history for trauma, if the patient say, I had an accident a few days ago and then I have this lateral chest pain, and then on palpation you will have tenderness, then you can think about rib fracture causing the pain. So we have like a wide variety of differential diagnosis for the chest pain. That's why it's always important to analyze the chest pain. Another symptoms are the fever, rigors, and night sweats. Those constellation symptoms are usually not specific to the lungs or to the respiratory system. They can happen whenever there is infection or inflammation in the body. If the infection in the lungs, in other words, they have a pneumonia, then the patient can present with fever, they present with cough, they present with chest pain, mainly pleurotic chest pain, they present with a shortness of breath. So fever itself is not specific to the respiratory system, but some diseases can present with fever. And again, infection, whether this is an acute infection like pneumonia or chronic infection, the common example for that is like TB, they can present with fever. Also, there is inflammation like vasculitis. If the patient has malignancy, whether it's a lung malignancy or lymphoma, both of them can present with fever. When a patient says, I have fever, then another question or another associated symptoms you should ask about is the rigors. Rigors is patient usually described as a body shaking. It's mainly a generalized body shaking. Some patient would describe that they were like, the patient would say, I have fever, but I feel cold. I'm shivering, I have this shaking, I have to cover myself under the blanket for a couple of minutes, and the shaking would improve. Then, in another word, the patient is trying to describe rigors. Usually, if a fever associated with rigors, then you should think that there must be, or the most likely, the patient has bacteremia, or like bacterial sepsis, the same name. Usually, gram-negative organism cause the bacteremia or cause the rigors. For example, if a patient has Pseudomonas pneumonia, then if along with the pneumonia, the patient will have bacteremia, have positive Pseudomonas in the blood, then the patient can present with a fever or rigors. Or a patient has pyelonephritis from E. coli, and the E. coli goes to the blood, and then we'll have gram-negative sepsis or gram-negative bacteremia, then the patient usually presents with rigors. Night sweats is another symptom, and patients would describe that like when they awake in the morning, they would say like the pillow is soaked with sweat, or like they have to change their clothes in the morning as they are drenching in the sweat. And night sweats also is an alarming symptom. Usually, if it's present with a weight loss and fever, then it's like a B symptom in lymphoma, or lung cancer can present with that. Actually, it's like most of the malignancy would be a differential, mainly the lymphoma would cause the 3B symptoms. TB can also present with the same way. Patient can present with dry cough, they can present with hemoptysis, they can present with fever and night sweat. And you would think, oh, could be a malignancy, but actually the patient has a TB that presents in a similar way of how the malignancy presents. Weight loss, again, is not specific to the respiratory system. Any chronic inflammation or any chronic infection can cause weight loss. And the reason behind that when you have inflammation, then the inflammation, you know that you will have a release of the cytokines. And these cytokines can suppress the appetite. So patients with chronic illnesses, like patient with chronic COPD or a patient with interstitial lung disease, they have inflammation, so they don't have a good appetite, so don't eat well, then you have the weight loss. Another serious cause of the weight loss, including the malignancy, lung cancer or lymphoma, can also present with weight loss. Sleepiness, I think this is the last symptom we're going to talk about today. Sleepiness described as excessive daytime sleepiness. Patient would say, sleepy all day, I sleep during inappropriate time or inappropriate places, and it's very annoying. Patient can sleep during their work, they can sleep during driving, which is, again, is a very dangerous thing to happen. Imagine like a patient like in the middle of the driving, they fall asleep. That's really serious and red flag. And the cause behind that, the most common cause, including in the respiratory system, is usually the obstructive sleep apnea. So what happened due to the obstructive sleep apnea? We know there is an apnea, it's called obstructive sleep apnea. So during the apnea attack, they will have hypoxia. And once the brain senses the hypoxia, then gonna stimulate the respiratory muscle to work heavily in a way to restore the breathing. And doing that, the patient will have a minimum or multiple awakeness throughout the day. It's very short, it's very minimum that the patient would not remember in the morning that they awake multiple times during the night. However, they will have a disturbed sleep and they won't enter in a deep sleep. So they won't get enough good sleep. So in the morning, they will say, despite like I had 8 hours of sleep, but I feel exhausted, I feel tired all the time, I feel fatigue all the time. Or some patient will have uncontrolled hypertension just from obstructive sleep apnea. When a patient presents to you with sleepiness, sometime or most of the time, if you ask them like, can you describe your sleep pattern, they won't remember. Because again, even if they are awake in the middle of the night, they won't remember that. So it's important to have a sleep partner that could describe their sleep pattern. And the most common presentation for that the patient will have first snoring, and then they will have cessation of breathing when the apnea happens. And when the brain stimulates the patient to have heavily breathing, then we'll have the snort, or which is a sudden loud sound. It's mainly that happened due to the restoration of the breathing. And most of the time, the patient would change position just in a way to help them to breathe better. So if a patient describes that, or if a patient partner describes that, then you would think this could be obstructive sleep apnea. Then you do the investigation for it, mainly the sleep study, to look into their sleep pattern. And the treatment is usually very easy. You just describe a CPAP for those patients, where as CPAP can help to prevent those patients of having the apnea attack, and they can enter in the deep sleep, and then they feel fine the next day, and the symptoms of sleepiness improve. Questions so far? All right. So once you're done with the chief complaint and you're done with the HPI, then you will go to post-medical and post-surgical history. The importance of post-medical history, because it can gives you a clue that could explain the symptoms that the patients have. For example, if you know that a patient has a history of asthma and they present now with a shortness of breath, then your top differential would be, oh, could be an asthma exacerbation. Again, also the past medical history could also help you to explain another systemic disorder that's not related to the respiratory disorder. For example, like a patient who is in the stage renal disease and present with shortness of breath, then you could think, oh, could be from pulmonary edema versus pleural effusion, maybe volume overload from inadequate dialysis. Or a patient with a heart failure present with a shortness of breath. So you could think, oh, could be an exacerbation of their heart failure. Those are some examples of how the past medical can help you in explaining your respiratory symptoms. Another example, if a patient has a history of eczema or history of childhood asthma, and they present with cough or they present with a shortness of breath, then you could think, oh, could be an asthma. Or a patient who says, I have hemoptysis, I have a dry cough, it's hard to be dry. I have cough, I have pleuritic chest pain, I was exposed to someone with TB or I got TB, then you would think, oh, it could be this is an exacerbation of the TB. Or a patient with rheumatoid arthritis or lupus, and then they present with a dry cough, or they present again with shortness of breath. So you could think, could the RA or could be the lupus causing the connective tissue disease? Both of them are connective tissue disease. They could cause interstitial lung disease. Could they cause lung fibrosis or pleural effusions related to that? Or a patient say, I had a malignancy before, I got chemotherapy or I got radiotherapy, cured from that, but now I have the weight loss, I have a fever, I have night sweats. Then you could think, oh, maybe this is a recurrence. I should do more investigation to look if there's a recurrence of their cancer. Or they could say, I had a cancer before, I had a lung cancer before, I got treatment for that, I got a certain type of chemotherapy, or I got radiotherapy, and I just saw my oncologist, and they say, I don't have a recurrence of the disease. However, I have this shortness of breath, or I have this dry cough. So you could think, oh, maybe the chemotherapy or could be the radiation cause a lung fibrosis, and that could explain their symptoms. So that's why it's very important to dig deep in the past medical history, because most of the time that would help you in your differential diagnosis. Again, past surgical history is also important, like a patient who say, I just recently had a surgery and I stayed in the hospital for 10 days. I was immobilized during that period and now present with a sudden onset of a chest pain or a sudden onset of the shortness of breath. Then you would think, could this be a PE? Or a patient with a history of seizure or a history of alcohol or liver disease, alcohol liver disease, then present with a fever, shortness of breath, cough. Then you could think, oh, maybe this is aspiration pneumonia that happened during the loss of the consciousness. Once you're done with the past medical and the past surgical history, then you can look into the medication and if there's any history of the allergy. And just looking into the medication list, you would be surprised to find many causes that could explain the symptoms. The most common example or the most common thing that you could see in the general practice is like a patient who is newly diagnosed with hypertension. The patient went to see their primary doctor and they prescribed lisinopril or the ACE inhibitor. 2 weeks after, 2 to 3 weeks after the patient came to the clinic and they say, my blood pressure is perfect, it's like all my readings are in below or around 120/80, but I'm having this annoying cough. I have this dry cough that presents all day long. All day, all night is very embarrassing. I can't go to the mosque, I can't go to the social gathering just because I feel embarrassed from this dry cough. Then only by just looking into the medication list, and if you see the Xenoprid or you see the ACE inhibitor, then you would know, oh, maybe the dry cough is likely from the ACE inhibitor. And once you stop the ACE inhibitor or change it to any other ARBs, losartan, for example, or any other ARBs, then the cough would improve. So just very simple, did not take a long of time from you, did not take a thorough investigation. By just looking into the medication list, you could diagnose the underlying cause of their dry cough. Another important medication that can cause respiratory symptoms, including a patient who's taking NSAIDs or taking beta blocker and having an asthma. So patients, if they are having an asthma, they say, like, most of the time I have an attacks of asthma, but when you look into their medication, you find they are on beta blockers or they're taking NSAIDs, then you would know that the main cause of the asthma exacerbation is just from the medication. Another example of medication, patient who or females who are taking birth control, like estrogen, mainly estrogen, you know that the estrogen can increase their risk of having DVT and having PE. So if they present with chest pain or they present with a shortness of breath or they are tachycardic or they are hypoxic, then you think, oh, maybe this is a DVT or a PE just from the oral contraceptive agents. I think we already discussed that. And then he will describe the family history, the social history. Is anything going on here? You're good? You have the family history and you have the social history. Usually the family history or like genetic disorders unlikely to present as respiratory diseases. But however, if a patient has a family history of asthma, that could run in the family, or a patient with a cystic fibrosis also can run in the family. The social history, when you ask about social history, it's important to ask about their daily activity, especially a patient who presents with shortness of breath. Like some patient would say, like, I live with the shortness of breath, I'm used to the shortness of breath. However, I'm having this shortness of breath for years, but in the last few days, it gets worse. And then you can ask them usually their daily activity. Are they able to go to do the groceries? Are they able to go to the mosque? Or their daily activity is just doing the bathing, the dressing, or the daily activity at home. So it's always important to ask about those things in the social history. Plus, you have to ask about the home circumstances. If they live in a house that is well ventilated or under ventilated, if they have pets at home, they have cats, if they have birds at home, that could cause the allergy or that can cause the exacerbation of asthma or the worsening of the shortness of breath. You should also ask about the smoking history, and you should calculate the pact per year. And usually you will calculate that by knowing for how many years the patient has been smoking times the daily packet. Like if a patient says, I've been smoking for 20 years, and usually smoke 2 packs per day, then that would be a 40 packs per year number. Occupational history is also very important when it comes to the respiratory system. And usually you should not only ask about the current occupation, you should ask about all previous occupation that the patient had, starting from the first job. Because many of the occupation that the patient could have could explain their symptoms. And if you just ask about the current occupation, then you will most likely miss your diagnosis. A common example for that is the asbestosis and the silicosis. Usually patients who work as a plumber or construction worker, they are more likely to be exposed to the asbestos. However, to have asbestosis, you know they should have enough exposure to that. So it's important to know for how long they have been working as a plumber or construction worker. And usually the manifestation does not happen within a year or two. You will find those manifestations around 20 years after their exposure. That's why it's very important to look into the occupation and dig deep in the occupation. Another example is a patients who work as a baker or like exposed to the floor, or work as a junior with exposed to the wood dust, that also can cause asthma. Or a patient who have birds at home, then exposure to certain antigen in the feathers of those birds can also cause hypersensitivity pneumonitis. And again, the patient can present with cough. They also can present with weight loss. And usually patients with occupational related symptoms, they would say, I feel worse during the work days. And whenever I go into a vacation or during the weekends, I feel better because, you know, like the antigen or the allergen that causing the symptoms mainly from the occupation. And when you take the patient away from that stimulant, the symptoms start to be better. I think this is my last slide. So again, once you're done with everything, you have to do a systemic review because you could pick something ongoing that could explain the respiratory symptoms. Again, I think I just gave you an example for that, like a patient with an ESRD present with shortness of breath. So we know that shortness of breath is related to inadequate dialysis. Or a patient with a PE, and then when you dig deep in the history, you find they have a vaginal bleeding, or they have abdominal pain, and they are diagnosed, and later on they are diagnosed with ovarian cancer. So systemic reviews is very important. You should do that every time you take history. All right, any questions? Any concerns? Okay, thank you.